Myself, Dr. Satyavijay. And coming to the case history, it's a 54-year-old male Hindu, a carpenter by profession from Varanasi, presented with the chief complaints of ulcer in the right little border of tongue since 5 months and right-sided neck swelling, which he noticed since past 15 days. Coming to the history of presenting illness, the patient was apparently normal 5 months back, initially noticed ulcer in the middle aspect of right lateral border of tongue, which was insidious in onset, gradually progressed to the present size. Initially, the ulcer was painless, but later was associated with dull aching pain in the past 2 months with radiation to the right ear. This relieved on with medication. He also gives a history of excessive salivation, and patient was not able to tolerate spicy foods. He noticed difficulty to protrude tongue for the past 1 month, and patient also gives a history of inability to pronounce few words. The patient gives episodes of bleed from ulcer while taking solid foods for which he was on semi-solid diet. Patient also noticed a single swelling on the right side of the neck, which was painless and initially small but attained to the size of marble over the past 15 days. He doesn't give any history of difficulty in swallowing and chewing. He doesn't give any history of decrease in mouth opening, no history of loosening of teeth, no history of sharp teeth, and no history of any dental extraction. He also doesn't give any history of weight loss or loss of appetite. He also doesn't give any history of cough, breathlessness, and hemoptysis. Coming to the past history, he has no similar complaints in the past, no history of any hypertension, diabetes, asthma, myocardial infarction, and stroke. Treatment history, no history of any drug intake, or no history of any surgical or medical interventions. Coming to the personal history, he has chewed tobacco in the form of pan for the past 30 years, which he has quit in the past 2 months. He has consumed alcohol for 20 years, around 60 ml per day, quit since past 2 months. He is married with 2 children, no history of any allergies, and takes mixed diet. Family history doesn't give any history of malignancy in the family members. Summarizing my clinical history, a 52-year-old male with history of tobacco chewing and alcohol consumption presented with a non-healing progressively increasing ulcer over the right side of the tongue for the past 5 months, which was initially painless but later associated with pain which radiated to the right ear. The patient developed difficulty in tongue protrusion, excess salivation, difficulty in speech, and unable to take spicy foods. Patient also noticed painless swelling in the right side of the neck, which was rapidly grown to the size of a marble in a span of 15 days.
Pain radiating to right ear. What does it indicate?
Sir, the supply, it's a radiating pain, sir, because
Yeah.
of the tongue is supplied by a lingual nerve, branch of fifth mandibular branch of trigeminal nerve, which also is auriculotemporal nerve, which is also a branch of V3. So it is a radiating pain which from the tongue is being referred to the external ear
Okay.
through
What is
uh,
glossopharyngeal neuralgia?
Sir, whenever there's a lesion of the posterior one-third of the tongue, which radiates through the tympanic plexus, and it is radiated in a deep-seated in the middle ear. Sir. It's radiated to middle ear. Sir.
Okay, it radiates to middle ear. Second thing,
Yes.
what does the excessive salivation and difficulty to speech suggest?
So excessive salivation is due to the sensory irritation, or either due to difficulty in deglutition, because of which saliva is not being deglutted to the pharyngeal phase. Sir.
Okay, so when the patient has a difficulty in speech,
Yes, sir.
which syllables he is unable to pronounce?
Sir, most common syllables are
Which your patient?
sir, he was not able to yes and R, sir. S and R were the syllables, which was rolling R and S, sir. Sabji and roti was the terms I asked him to repeat, and he has
There is
difficulty
there
in.
is there is no rolling R in Hindi. Rolling R is there in Malayalam.
Asked him to say roti, sir, but
Roti is not a rolling R. Parram is a rolling R. Marra is a rolling R. There are
okay,
no rolling R. There is no rolling R in Hindi.
sir.
Or which sound is produced by which part of the tongue and which movement of the tongue?
Lingo, alveolar speech and linguopalatal speech are the difficulties which he was not able to. It indicates intrinsic as well, intrinsic muscle probably invasion, because of which the tongue has not been modulated either at the tip or by the lateral sides of the tongue. So coming to general examination, the patient was explained the procedure and was examined and well led to him after taking consent. Was conscious, alert, oriented, time, place person, ECOG score of 1, BMI of 18.5, BP was 130/80 on right arm in supine position, pulse rate of 85 per minute in the right radial arm, febrile, respiratory rate was 15, and thoracoabdominal regular, no pallor, icterus, clubbing, pedal edema. Cervical lymphadenopathy is present, which I am explained in detail in later. There is no generalized other lymphadenopathy noted. On inspection of the oral cavity, there is adequate mouth opening, 3-finger breadth, and there is a 3 into 3 centimeter irregular shaped ulcer noted involving the right lateral border of anterior two-third of the tongue, extending from the tip of the tongue up to the circumvallate papillae posteriorly. It is crossing midline at the tip. The rolling out edges are present. Floor is covered with slough. He is unable to protrude tongue beyond the oral cavity with deviation towards the right side. There is a poor orodental hygiene with halitosis present. No loose or sharp teeth noted. There is a tobacco staining noted on the teeth, and no other lesions are noted in the rest subside of the oral cavity on inspection.
So what are the muscles involved now?
Sir, extrinsic muscle like genioglossus I'm suspecting to be involved, sir.
So why did you say intrinsic muscles in the when I asked you in history?
So both the intrinsic and extrinsic, sir, like both help in the modulation of the tongue. So this help, both of them help in the speech, sir. Actually.
See, patient is giving a history of excessive salivation, difficulty in deglutition. He is not able to articulate, especially the palatal words. You should suspect the involvement of extrinsic muscles, especially the anterior suspenders.
So Vijay, what are these muscles? Extrinsic
Uh,
and intrinsic, enumerate.
Ma'am, intrinsic muscles of tongue are 4: longitudinal, horizontal, vertical, and and coming to the intrinsic muscles, these are genioglossus, hyoglossus, palatoglossus, and styloglossus.
How did you examine the tongue on inspection?
On as there is adequate mouth opening, sir, like I've asked.
Did you ask the patient to protrude the tongue?
Yes, sir. I asked the patient to protrude the tongue. He was able to protrude up to the oral cavity opening, sir. I mentioned it, sir. With
So
the deviation.
was there any deviation of the tongue?
Yes, sir. Deviation is present towards the right side, sir. I mentioned it, sir.
So it's deviated on the same side of the lesion?
Yes, the same side of the lesion, sir.
So what does it indicate?
Opposite side muscle is active, and the same side muscle is not functioning because of invasion.
Get involvement of muscle or involvement of a nerve?
Sir, it could be either, sir, a nerve or muscle.
So how will you differentiate that it is because of involvement of a muscle or involvement of a nerve?
Sir, if it is a
And if
involvement
it is
of
a nerve, which nerve are we talking about?
sir, hypoglossal nerve, sir. If nerve is involved, all the movements of tongue will be affected. Like you will be not able to either retract the tongue.
So what functions are present in the tongue?
Sir, unilateral genioglossus is working, so there is a protrusion towards the affected side.
You said genioglossus was involved.
Yes, sir. The opposite side is functioning, so the normal side is being diverted to.
You focus on the disease side. Why are you focusing on the normal side? So you tell me the nerve supplied, muscle supplied by the hypoglossal nerve.
So supplies all the muscles of tongue except palatoglossus, sir,
Which is supplied by?
which is supplied by 10th nerve, sir. Vagus.
And what kind of nerve is this hypoglossal?
Hypoglossus is a muscular nerve, ma'am. Completely.
Muscular?
Sorry, motor nerve. Pure motor nerve, ma'am.
Could you test for the other muscles which are supplied by hypoglossal nerve?
The movement.
Three muscles are supplied.
Yes, sir. Genioglossus is for protrusion, and for retraction, styloglossus, and for depression is for hyoglossus muscle, sir.
So what are the functions which are present and what are the functions which are not present?
So protrusion is absent, sir. So I couldn't elicit whether the patient is able to retract it or not, sir, actually. And I have not looked for the elevation of the tongue, sir. Like was not elicited.
It should have been elicited because this is what you have to differentiate.
Yes.
Why it is important to know whether hypoglossal nerve is involved or it is only the muscle involvement by the tumors?
Sir, if hypoglossal nerve is involved, it should be included in the resection specimen, both the proximal and distal. Like we have to see that distal proximal margin should be negative, and if one side is not functioning, the function it can For reconstruction purposes, sir, like we are planning a functional unit is required. Usually opposite side functional unit is required. Inspection I finished, sir. So next I'm coming to the palpation. The inspectory findings were confirmed. There is a 3 into 3 centimeters single irregular shaped ulcer infiltrative lesion noted involving the right lateral border of anterior 2/3 of tongue, extending from tip of the tongue up to the circumvallate papillate posteriorly. It was crossing midline at the tip. The edges were rolled out. Floor is covered with slough. The ulcer was tender on touch. There is a bleed on touch present. Base is indurated, and induration is noted around the entire ulcer for 0.5 centimeters, and it is found crossing the midline at the tip of the tongue. Base of the tongue, tonsil, and the floor of the mouth appears free of induration and ulcer. There are no other lesions palpated on the other subsides of the oral cavity.
So
On examination of
so on palpation,
yes, sir.
your floor of mouth is free.
Yes, sir.
So that means there is no involvement of extrinsic muscles.
Sir, floor of mouth is mostly formed by mylohyoid, and there can be a chance of involvement. Extrinsic muscles can be involved, sir.
What position do you examine the tongue in for during palpation?
Sir, for palpation of tongue, the tongue should be inside the mouth. It should not be
Why?
protruded outside.
Why?
Sir,
Why?
it gives a false induration sensor if it is
Right.
protruded out. And so on neck inspection, there is a 1 into 1 centimeters discrete nodular swelling with smooth surface noted in the right level 1B. Skin over the swelling is normal, and similar kind of swellings are not found elsewhere in the neck. On palpation, neck palpated from behind while patient is sitting on a stool with neck being passively flexed. It is non-tender, no local rise of temperature noted. A single 1 into 1 centimeter nodular hard mobile node palpated in right level 1B, and no similar nodes palpated in either in the ipsilateral or contralateral side of the neck. Systemic examination, cardiovascular, respiratory, CNS, and spine bone exam. Coming to the case summary, a 50-year-old male with a history of tobacco chewing and alcohol consumption presented with a non-healing, progressively increasing in size ulcer over right side of the tongue for past 5 months, which was initially painless, later associated with dull pain, which was radiating to right ear. Patient developed difficulty in tongue protrusion, excess salivation is present, difficulty in speech, unable to take spicy foods. Patient also noticed painless swelling in right side of neck, which is rapidly grown to the size of a marble in span of 15 days. On inspection and palpation, a single 3 into 3 centimeter irregular shaped ulcer-infiltrative lesion was noted involving the right lateral border of anterior 2/3 tongue, extending from tip of the tongue to circumvallate papillate posteriorly. It was crossing midline at the tip with an indurated base. Induration was noted around the entire ulcer for 0.5 centimeters, and it is crossing the midline at the tip of the tongue with restricted tongue protrusion. And there is a single palpable lymph node on the right level 1B. With this case summary, I have a provisional diagnosis of malignant lesion of tongue with nodal metastasis.
And no staging.
What's the clinical stage?
So clinical stage, I would like to have C T3N1 M0, sir.
Why? Why T3?
Sir, because of suspected tongue protrusion and
You said there's deviation of tongue, right? Why do you
uh,
think it's why do you still call it T3?
Sir, actually, T3 is based on depth of invasion, sir, which I couldn't elicit depth of invasion in clinically in this patient because he's not able to protrude the tongue. But because of lack of proper protrusion of tongue, deviation of tongue towards the affected side, and radiation of the pain, I suspected a deep lesion, sir, with more depth
No,
of
but
invasion.
when deep muscles of tongue are involved, clinically are they involved or they're not involved?
Clinically, they are involved, sir.
So what stage is that?
Sir, according to IGCC 8th edition, like depth of invasion is taken rather than the extrinsic muscle invasion, sir, which was considered in 7th edition.
What is the size of a marble?
Actually, patient has given it's roughly 1 into
I'm
1
asking you,
centimeter.
have you ever played with marbles?
Yes, sir.
What is the size of a marble? Or how many sizes do they come in?
1 into 1 and 1.5 into 1.5 centimeters.
See, when you are comparing the sizes, you should compare with something which comes in a fixed size. You should not
Yes,
compare with something which comes in different sizes. It
yes,
comes sizes as small as 5 millimeters to as large as 5 centimeter. If you have to compare it with something which is of 1 centimeter, think of something which is standard 1 centimeter,
yes,
not something which can have a variable size. So when you say
yes.
marble, I don't know how big a marble you are talking about. Okay.
Sir, as a diagnostic workup, I would like to have a biopsy and I would like to have an MRI of face and neck, a chest X-ray, and routine blood investigations of the patient. Sir.
Why do you want a MRI of the face?
Tongue, sir. I've written by mistake wrong. So it's a tongue and neck, sir.
There are no mistakes in surgical oncology.
Sorry, sir.
Okay. So what is your biopsy?
Sir, biopsy was a well-differentiated squamous cell carcinoma, sir.
Okay.
And
What are your MRI findings?
sir, MRI findings initially is a contrast phase, sir, showing a lesion on the right side of the tongue crossing the midline at the tip. And the second is a T2 lesion.
Why was a contrast MRI done?
Sir,
What is the indication of contrast MRI here?
sir, usually contrast MRI is indicated when to find out the occult lymph nodes, sir, with the fat suppression and.
Why did you do a contrast MRI here?
Sir, actually, he got it done. He got an MRI done outside and came, sir.
Okay. So what does it
And the second image is a hyperintense on T2, the same finding crossing midline on the anterior tip. And the third is a hypo on T1. And the third image shows two lymph nodes of around 1 into 1 centimeters and right level 1B. And the last is a sagittal section showing right literal border of tongue with the free floor of mouth, sir. And base of tongue is also free. And second image. So come 3.8 into 3.2 into 2.5 centimeters, enhancing ulceroproliferative mass lesion seen along the right lateral border of anterior two-third of tongue, crossing midline along the tip of the tongue with depth of invasion of 1.5 mm. The lesion is invading anterior fibers of genioglossus. The fat planes are lost with right sublingual gland. Base of tongue and floor of mouth appears normal. There is enlarged lymph nodes in right 1B, the largest of 1 into 1.1 centimeters.
Now you say that lesion is 3.8 into 3.2 into 2.5 centimeters.
Yes, sir.
And then you say the depth of invasion is 1.5 mm.
Sir, actually, the depth of invasion was not mentioned, sir. It was actually being discussed, and they told it will be mostly greater than 1.5 mm. Exactly, they couldn't tell because they couldn't have a console.
1.5 mm.
Sorry, sir, 1.5 centimeters, sir. I've written mm. So I'm extremely sorry, sir. It's a mistake. I've written 5 centimeters, sir.
And what are the three dimensions? 3.8 into 3.2 into 2.5?
Sir, anterior, posterior, medial, lateral, and complete thickness of the ulcer, sir.
So how the complete thickness of the ulcer different from the depth of invasion?
Sir, depth of invasion is taken from the horizontal line at the normal mucosa. A plumb line is drawn vertically up to the deepest part of invasion. That is taken as depth of invasion, and it is usually seen pathologically.
So how do you see depth of invasion on a CT scan, on a MRI?
Sir, MRI scan gives a rough estimate of depth of invasion from the adjacent normal tongue to the deepest part on the sagittal section.
So that they have given as 2.5 centimeters, isn't it? See, once you have the X, Y, and Z axis, the Z axis is the depth of invasion.
But the thickness can be proliferate to edges are present, sir. So it could have added to the thickness of the original ulcer.
But you have described your lesion as a ulcero-infiltrative. You have not described your lesion as proliferative.
Sir, actually the edges were rolling edges have written, sir. Like I've changed it to infiltrative because of on palpation there is induration palpable beyond the ulcer edge. Sir. Sir, irregular ulcer infiltrative lesion involving right lateral border of tongue.
So
And the induration.
ulcero-infiltrative lesion is not proliferative. That means the tumor is not extending beyond the tongue. It is infiltrating into the tongue. So either this is wrong or your inspection is wrong. One of the two is wrong.
Right, just were rolled out, so probably there can be a mismatch from the normal surface which they have taken. So.
No, I'm asking you. I'm not concerned about MRI. I'm asking you. We are discussing your description of the ulcer. You at two places you are defining the ulcer in two different ways. And if you look at the clinical photograph, there is no rolling out of the ulcers. See the clinical photograph once again.
Yes, sir.
Where is the rolled out ulcer edges? See, you have to define your. You have to learn how to define your ulcer, because in head and neck, that is the only thing that you need to do. Okay.
Yes.
So you have done an MRI. So what is your final staging?
Sir, my final staging is CT3 N2B M0, sir. Stage 4A, sir. I would like to give a pre-surgical counseling for the patient regarding tobacco de-addiction and have a speech and swallowing pathologist therapy and evaluation.
But
And
you told that your patient has already left tobacco.
yes, sir. Uh, just making sure that he doesn't
But
consume.
then you told in the history that patient has given up the tobacco.
Yes, sir. He has given her.
So why does he need the counseling for giving up on tobacco? Because he is not currently on tobacco.
So that he doesn't again restart again while we are on treatment or next successive adjuvant treatment whenever it is
How
going
long
on.
before he left the tobacco?
2 months, sir.
Has he started in 2 months?
No, sir. He has not taken in
So
past
why do
2
you
months.
think he'll start after your surgery?
Sir,
What
once.
made you think that patient will start eating tobacco once the surgery has been performed?
Yes, sir.
What are the factors that influence restarting of tobacco habits?
Sir, once he is either pain-free or once the surgery, he feels that the treatment has completed after surgery.
So what are the kind of people who will restart and what are the kind of people who will not restart? You know that this patient will restart and this patient will not restart.
Sir, if he has dependence on the
He has already left it for 2 months. Now you're talking about restarting. See, first you said you will counsel him to leave the tobacco. When you were
yes, sir.
told that he has already left tobacco, you said, I want to counsel him not to restart. So why do you think he will restart after leaving for 2 months? Or what are the factors which lead anybody to start tobacco, give it up, and restart tobacco?
Sir, actually the constant nicotine levels he requires.
See, Satyavijay,
Yes,
you speak something wrong, you get into soup, and your viva goes into that direction. It has been told to you multiple times. So tell me, what are you going to do? Patient has a T3 and to be M0.
Sir, after speech and swallowing therapist counseling, he will be planned for an upfront surgery, sir. He will be explained regarding the uh, further excision of the tongue and the reconstruction options to the given to patients, and post the surgical speech and swallowing therapy to be continued.
Okay, so what are
And
the problems that you think he will have after the surgery?
sir, complications initially immediate post-op complications, sir, like
Vijay, you have
uh,
not planned what surgery you are going to do. So how will you know that what will be the deficit?
yes, sir.
You
The
have not
deficit will
planned the
be
surgery. So how can you do
yes,
the
sir.
counseling before planning the surgery?
Yes, sir.
You have
Sir,
not planned the extent of a resection.
yes, sir.
So you don't know what are you going to take out. You have not told us. So if you don't know, then how are you going to counsel? So the first step is to plan what surgery are you going to do.
Yes, sir.
And the
Sir,
second step is to inform the patient that what will be the consequences.
yes, sir.
You are going other way around. You are going to talk about consequences first without knowing what planning are you going to do. First, you have to say what will be the extent of your excision if
Yes,
you are
sir.
going for a upfront surgery.
Yes, sir.
Then tell us about what will be the consequences of that and how you
Yes.
plan to take care of them.
Surgical wise, I will be planning for a subtotal glossectomy with neck node dissection of ipsilateral side and contralateral side with the reconstruction option of a free microvascular flap. Uh, and I will explain him regarding the possibility of chances of intra or post-op tracheostomy in view of a bulky flap.
So, what is a
Depending,
subtotal glossectomy?
sir, there's a classification of glossectomies where the subglossal glossectomy is a type 4 glossectomy, where the bilateral base of tongue and the posterior hyoglossus are preserved, with lesser involved side hypoglossal and lingual nerve being preserved. Usually done for lesions of the anterior tongue lesions crossing the midline with genioglossus involvement, sir.
Hmm. It is how many types of type 4 glossectomies you know of?
Sir, there are four types of type 4, sir, A and B.
Huh.
Uh, where type 4B is a near total glossectomy, sir, where contralateral hypogloss and stylogloss are preserved. And even the ipsilateral of base of tongue is also excised, sir.
And why do you plan to do bilateral neck?
Sir, it is crossing midline in the anterior tip with induration crossing the midline, sir. Both the ulcer lesion and the induration crossing the midline, sir.
Okay. So
And
on what evidence your decision to do a contralateral neck is based on?
sir, whenever there is a locally advanced lesion with the ipsilateral suspected lymph nodes, the contralateral 30% positivity that the contralateral nodes are positive, sir.
Which trial is it?
Not sure about the trial, sir.
What are the trials of neck dissection in lung cancers?
Sir, few trials I know regarding the N0, sir. There's a SEND trial in UK
No,
regarding.
we are talking of N
Sir,
positive.
I'm not
You
exactly sure about the trial name, sir.
no, if you are not sure about, you have a N2B lesion and you want to do a bilateral neck in a patient, you should know on what evidence your decision is based on.
Sir, in NCCN, they have mentioned regarding the uh, lesions crossing the midline and base of tongue lesions, or where the chances of contralateral node positivity is high. I'm not sure about the trial, sir. Sorry.
You have a N0 contralateral. So what is the basis of taking a decision that you want to do a neck dissection on that side also?
No idea of the trial name, sir, regarding the contralateral.
This patient has two 1 centimeter nodes in level 1B.
Yes, sir.
There are no nodes in even 2, 3, 4. So what is the basis of doing a modified neck dissection on the same side? And what is the rationale of doing dissection on the other side? That's the question.
Yes, sir. Same side, there's a observation by Byers et al., which showed that whenever there is a level 1 and level 2 lymph nodes are positive, there are higher chances of skip lesion to level 4 up to 15%. This is a rationale for doing.
Any other
modified.
trial you know of? There is a lot of data from India.
Yes, sir. But those trials were recent trials were showing that if it is an N0 neck, the skip metastasis for 3%, sir. So there's a trend has changed. The skip metastasis, which was seen in the earlier studies, was seen in both N1, sir, where the lymph nodes are positive.
There is data on N positive nodes also.
That was your study, Dr. Pandey, or it was from Bakkal Mikosa?
Mine.
Yeah, I remember.
Both
Yes.
Bakal Mikosa and tongue are mine.
Right. Bakkal
And
Mikosa, I remember.
see, the student doesn't know my studies.
This is another big thing. You must search the articles published in the department by the department. I think Dr. Pandey also has a series on sentinel lymph node also, है ना, Dr. Pandey?
Yeah, that was your colleague's thesis.
Yeah.
First thesis in the department for MC.
I remember.
See, Satyavijay, for a short case,
Yes.
the only thing you have to do is defend your treatment decision.
Anybody else from third year's exam going batch can also answer. How do you decide to dissect the other neck?
Other people don't read and come. Yeah.
Sir, the incidence of positive nodes increases with the T stage. And also with the and in the CA tongue cases, if the patient has N1 clinically N1 or N2 node, then that increases the significant risk of developing node metastasis in opposite neck also. So and also that the tongue lesion crosses the midline in the tip, and also also in the midline also. So there should be opposite neck dissection.
Sandeep, you are forgetting that ipsilateral neck dissection in a N positive is a therapeutic neck dissection.
Yes, sir.
Contralateral neck dissection in a N0 is a prophylactic neck dissection.
Yes, sir.
It's not
Yes, sir.
therapeutic.
Yes, sir. It's prophylactic
So
only.
now you have to justify contralateral prophylactic neck dissection.
Sir, because suppose we have operated as a case of CA tongue with wide excision and ipsilateral neck dissection, and if the contralateral neck dissection develops after that, the probability of survival in that patient is very low, decreased to very much. So we have to we have to do the we
So
should do the
which study is that, and what is the where this data has come?
only trial I remember is a bias trial. Other trial I don't remember.
See, again, the trials from India you don't read. This data of contralateral neck from the tongue is again from India. It is Mukherjee's. And he has shown contralateral node involvement is 9%. And that is mostly in the floor of mouth involvement. And of
Yes.
that 9%, the occult metastasis in a N0 neck is only 4%. So in case
Yes.
you are doing a prophylactic contralateral neck dissection, 96% of the time you are doing over treatment of the disease. Are you going to give adjuvant in this patient or not?
Yes, sir. I'll give adjuvant treatment in the form of if in the form of RT. Yes, sir.
So what will be the field of the RT when you give his adjuvant?
It will include the tumors. It will include the tumor site and the neck.
So is it going to
B-
include one side of the neck or both side of the neck? So then why do you want to do a prophylactic neck dissection? What kind of a adjuvant are you going to give here? Is it going to be a plain RT or concurrent RT? Concurrent
Sir,
chemo RT?
Sir, it depends upon the histopathological report and
COP stage is also T3 and 2B M0.
sir, if margins are negative and there is no extranodal extension, patient will get only adjuvant radiotherapy, sir, instead of chemoradiotherapy.
So what are the side effects of rather complications of neck dissection and bilateral dissections?
Ma'am, complications of neck dissection, post-surgical hemorrhage, hematoma formation, flap necrosis, and nerve palsies, and seroma formation and infection.
No, you first tell me, are there any complications that can happen on table?
Nerve injuries or mainly the phrenic nerve and spinal axillary nerve, which comes in the field of dissection.
And
Phrenic nerve does not come in the field of dissection.
Sir, not in the field of dissection, sorry. Like if you breach the fascia and go, then the phrenic nerve can be injured. And if you phrenic, brachial nerve, and spinal axillary nerve injuries.
so these are neural injuries. Anything else that can happen on table?
Any of on lymphatic duct injury can also happen. And
Lymphatic duct, what is it called?
thoracic duct injury, left-sided chyle leaks can happen.
And have you heard of air embolism?
Yes, ma'am. Like through the IVC, not IVC, IJV, ma'am, internal jugular vein
So what happens? How will you detect?
decrease in the venous return.
How is an air embolism detected on table?
Sorry, ma'am, no idea.
So you are doing a type 4A
Yes, sir.
glossectomy.
Yes, sir.
How will you reconstruct?
Sir, my first option will be a microvascular free flap reconstruction, sir, to cover the defect. And as I'm suspecting a defect more than half, I will like to select anterolateral thigh flap, sir, which can add bulk to the tongue.
And if you are planning a type 4A, what are the speech and deglutition problems patient is going to face?
Sir,
What will you tell the patient? What he will not be able to do after you have done a type 4A glossectomy?
Sir, after an adequate speech therapy, he will be able to present his intellectual speech to the same level, sir. Around 73% he can achieve it after an ALT flap reconstruction.
So speech is measured in terms of percentage, huh?
Yes, sir. Like number of clear words that can be understood. Speech intelligibility is the term used.
So what are the syllables again he will not be able to pronounce? So what are the various tongue movements which are necessary, or what are the various sounds that you know of?
T, D, L, and rolling R are the basic pre-surgical tongue, the phonetics by the tongue, sir. I'm not very sure about post-surgery, how many syllables he'll be able to pronounce, sir.
Why not? You know exactly what you're taking out in a 4A glossectomy, and
Yes,
you know
sir.
what you are leaving behind. So, what are the necessary movements of the tongue for pronunciation?
Lateral muscle retract folding, sir, and the tip rolling, and uh, palato retraction of tongue, sir.
Is this how you classify?
No, sir. It is classified based on the site of the defect and the amount of defect, sir. Whether the lateral tip or the dorsum is involved, and how much is the amount of defect, less than one third to half, and more than half.
You have not read articulation.
Satyavijay, any role of neoadjuvant chemo in this?
Sir, neoadjuvant role in resectable cancers are being studied in two trials, Listra and Zong, and both the trials have shown that there is no improvement in the overall survival in resectable oral malignancies. But they have shown that if a mandibular preservation is seen in 21% of patients, and the response seen to the induction chemotherapy can give prognosis of the tumor, sir. These two, I think, but there is no survival benefit in neoadjuvant chemotherapy, sir, in operable upfront cases.
So, there is no survival benefit in breast also, isn't it? Am I
But
right or am I wrong? Does neoadjuvant chemotherapy increases the survival in breast cancer?
no, sir.
So, why it is used there?
Sir, as a preservation, sir, as
What
an
about
organ preservation.
what about last seminar on gastric cancer? Does it improve survival? So, what does it improve?
The
Why is
organ
it used?
preservation, organ preservation, sir.
So, is organ preservation possible in this patient?
So actually, the two trials which have shown in the operable neoadjuvant chemotherapy, they were not very much specified to particular subsites, sir. They have shown that they have preserved mandible in around 21% of patients. They have not commented regarding rest of the sites regarding and they have taken in which the Zong trial have taken the margin from the newer lesions, the shrunken margin, whereas the Lister has taken the margin from the previous primary lesions, sir. But both of them have shown that there is no positive margin in any of these. There are 3% positive, but positive margin, but there is no that is less than 5 but there is no complete 100% positive margin, sir.
But that doesn't answer the question.
Yes, sir. Like the neoadjuvant can be used as a thing for preservation, sir, according to these trials. So, but it is still in clinic. These are under only clinical trial phase only. It has to be given, sir. Like
See, Satyavijay, when you are going to talk about head and neck, you have to read Indian data because in head and neck, majority of the data has originated from India.
Yes, sir. I have one question. Sir, in a case of tongue lesion, T1, T2 lesion, in which the muscles are not, the external muscles are not involved, can we say CT is equivalent to MRI? Look, if someone asks me, ki, I want to get a CT, not MRI, can we say it is, yes, it is feasible, or yes, it is equivalent?
That answer should come from Satyavijay.
sir, in lesions of tongue, not just the bone involvement. I would like to see a perineural invasion, and soft tissue will be muscle involvement is more detailed in MRI. I can see the how much of volume of tongue can be resected, based on which I can plan whether floor of mouth is involved, which is more better in MRI. I can plan a reconstruction plan more than on CTI. It is so I prefer MRI, sir.
Yes, the MRI for soft tissue is always better. So, what are the indications of mandibulectomy in tongue cancer?
Sir, mandibulectomy, I would like to, depending upon whether segmental mandibulectomy and marginal mandibulectomy, sir. And if whenever the floor of mouth is involved and there is no cortical breach, but just regarding a margin, then I would like to prefer a marginal mandibulectomy in patient. And if there is a frank cortical invasion from the tongue, floor of mouth extending into the cortical invasion with, then I would like to prefer to do a segmental mandibulectomy, sir.